Same for this now for the second session, the second lecture in this part. We have Ms. Penny Davis. She's a community education specialist here with the Department of Internal Medicine, Division of Geriatrics, and Senior Services Office. And she's going to be talking about paying for medical care, the good news and the bad news. This, by the way, is water aerobics that Ms. Davis participates in. And it's a really great program that they do through the Senior Services Office. She could probably tell you more about it because I think you sponsor it and you know, put that all together. It's one of the programs that they do in Senior Services, which is really great. But real briefly, Ms. Davis received her master's degree in '97 in social gerontology, adult education administration with distinction at the University of Incarnate Word in San Antonio. She's participated in Medical Rights Center training in Galveston and in Houston, and she states as her education objective to take her comprehensive knowledge of UTMB, its clinics and physicians, and combine it with an extensive network of providers, organizations, and other contacts to market, educate, and promote what she believes in UTMB. That's a great statement. I just had to put that on there. I really think that that encompasses what she does very well. She began working with us in 1999 as a community educator specialist, as I said, with Senior Services Offices. So without further ado, Ms. Penny Davis. Let me get you this.
The Senior Services Office, we do offer a lot of health and wellness programs, so I participate in that. And in the swimming class, and it did tell me that someday I think I'm going to have to do something about actually getting a photo picture. But I do want to talk to you about Medicare. Good news, bad news, well put, and some of it's even terrible, I believe. And I think the thing we have to do is be very much aware of what's going to happen, because it's going to affect, it's going to affect every one of us. The current Medicare program is equilaterally applied to everybody across the board, so everybody was treated the same, which was a disadvantage for low income because getting prescriptions and things like that has been a major problem for them. We're going to swing the other way now with the new Medicare, because it's going to be separating the groups in coverage, and the people most helped are going to be the low income, especially due to the drug program that comes with it. And probably the people that aren't going to get much help out of it are going to be the middle income. And then the next group that'll get a lot of help is going to be chronic, only because they have extensive medical bills. To understand a little bit, we have to know, what does the consumer have to pay? Medicare covers, in the hospital, the first full 60 days free. So what the consumer has to pay out of pocket, first of all, is every time they go into the hospital, $912, just across the board deductible, unless they return in 60 days for the same illness. If they're in the hospital more than 60 days, we're looking at co-pays of $228 a day up to the 90th day, $456 the 91st day and plus. And additionally, if they go into skilled nursing, which happens a lot because the hospital takes you to a certain point, and rehabilitation is done in nursing homes, skilled units, specialized hospitals, the first 20 days is covered completely, but then from the 21st to the 100th day, it's $114 a day copay. And after that, it would be private pay or being accepted into long-term care. Also, home health is covered completely. There's no deducts or co-insurance. Hospice care, that has no deduct but does have a small copay for outpatient drugs. Part B, which is your clinical and your outpatient, right now $78.20 a month comes out of everybody's Social Security check, for their Part B coverage. Medicare pays 80% of approved services. The patient has to pay 20% of all approved services. And that's after a $110 deductible at the beginning of the year. And this is going up every year. Last year it was $66. This year it's $78. Next year they anticipate $98. And if you've got somebody in a moderate income, they got $100 a month coming out for this, and they're going to have Part D coming out. There's some people who won't be able to afford medicine eventually, even in the middle class. Also, if Medicare doesn't approve a service or a procedure, the person's going to pay 100%. They'll also be responsible for a surcharge. In Medicare, doctors can accept the Medicare level of payment, and so that's fine, whatever Medicare agrees to pay. But a lot of doctors, awful lot of them, are going toward this, charging above the Medicare rate. They participate, they process the paperwork, but they charge more. And that comes out of pocket unless you have coverage for that. And mental health services are covered at 50%. And prescriptions right now, there's 3 policies that have partial coverage, but that totally goes away in 2006. That will no longer be available. So the question is, how is somebody going to pay for this? Currently, and just a lot of these will also be available in 2006. Options for paying are out of pocket. HMO plans, those are coming back into the area, some with additional service. You can purchase a supplement. You can purchase a Medicare Select policy that's called Choice, Medicare plus Choice. There's assistance programs. Then there's specialized programs different hospitals and clinics have, and I'll give you an example of one we have at UTMB. If all else fails, they can move in with the kids and let them pay. Oh, okay, yeah. First one we'll look at are the state assistance programs.
That's the red button.
Oh, the red button. Okay. And these are for the low-income people. We have people on disability who are disabled before age 65, and those people, after being disabled for 2 years, can get on Medicare. And we have the SSI people. If people's income is really low, then they get the income, they get their income raised up to the $584. But the thing that is really critical is they get medical coverage that pays all the co-pays, deductibles, pays their prescriptions, as well as the Medicare premium. And of course, they have to have low resources. Then we have the next group in the community, and they have some help here. It's SLIM. That pays strictly the Part B, which is going to be significant when it gets up to $98 or more a month coming out. We have the QMB. It not only pays Medicare Part B premium, but it pays deductibles and co-pays. But you notice you really got to be low income to qualify for these. And they look at gross income, and they also look at resources. They have community care, but that's aid services in the home, so there's no medical assistance there. We have the community-based alternative that provides medical services in the home when they feel they can offer cheaper in the home than they can in a nursing home. Yes?
Are all those income limits monthly gross? Or
monthly.
Gross.
Monthly gross income. And when they look at income, they're looking at Social Security, pensions, proceeds like from oil wells or things. If they had an oil well, well, they might not be here though. And then we have some new programs that came in. They don't know how to change certain programs, so they just add a rider program. So Medicare Part A will be covered under a acuity program. They've got a QI program that helps cover Medicare Part B. But most of those are extremely low income. Now, I talked about specialized programs that some places offer. And I always encourage you, if you're working with patients, make them aware of this, because most of these programs aren't advertised. You've got to ask. And UTMB has one. And it's fairly generous. If somebody's got $1,436 a month or less as an individual, they can get prescriptions for $10 right now. If it's generic, $25 for brand and higher for restricted drugs. The real benefit on this, though, is it also picks up all the copays and deductibles. So we've got a lot of people on this, and it isn't necessarily just the elderly. And they have a program also, a second tier, where it pays 50% of everything. How this is going to change when the new Medicare law comes in, I have no idea. But I think people just need to constantly look and search for whatever there is.
And just with those programs for UTMB, who develops those? I mean, where does UTMB get the ability to be able to offer those kinds of programs?
It has to be built somewhere in their budget and funding that comes down, and someone must develop it to me and present. We got this big block of people that need help, and we're not getting coverage. And I'm sure there has to be some supplemental money behind it, because it's a costly program, I would think.
So the UT system?
Probably, be my guess, yeah.
Comes up and maybe gets with state
right. And then I know, like in San Antonio, some of the other hospitals have special programs there. I know that when my father was alive and had heart things, and they had a lot of things they offered there for family and people. But, you know, you ask and find out.
How is this related to Choice One's benefit?
Oh, Choice One is different, which we'll cover.
Because this is just prescription that you're talking
yes.
about right now. UTMB's prescription.
Yeah, the Choice One.
Well, Choice One, if people apply for Choice One and their income's low enough for this, they're switched to it. So now we have another choice for covering medical expenses, of course, is health maintenance organizations. And they're very good on cost containment, but they have rules to follow. You use the network, we all know. You have to have a primary care physician. There's no coverage away from home except an emergency, none outside the United States. And what they are doing too, some of them have a point of service option, which means, okay, you can go outside the network, but you're going to have to pay bukus of money. Because under an HMO, the Medicare becomes the property of the HMO and they control it. So when you go outside of the, or if you go outside the network and want to go to some specialist in cancer up at MD Anderson and they're not on this list, you don't have your Medicare that's going to pay that 80%. You're going to end up paying the whole bill. And some of these, under the new Medicare law, these plans will be available. They're going to call everything Medicare Advantage plans. Then we have supplemental insurance. It's called Medigap, closes the gap between Medicare and your pocket, or referred as supplemental. And they all have basic things in common: hospital co-insurance, cover up to 365 days of full coverage on top of Medicare cover days, and pays a 20% through your clinical and outpatient type medical bills, and covers the first 3 pints of blood. That's what they all have in common. And where they differ are under these points right here. Is additional coverage, you can get your hospital deduct covered. $912, you know, that's a hunk to pay, especially if you're in and out of the hospital a lot during the year. Skilled nursing co-insurance at $114 a day. Emergency outside the United States, and that's important in Texas because we are a border state, number one, so a lot of people go over the border. And also with the cruise ships here and everything, people are traveling a lot outside the country. And that excess charge, that 15%, some policies cover that. Preventive care and limited prescriptions. But for everything extra you get, you're paying more for it.
So Medicare does not cover even emergency outside of the country?
No.
Even emergency, huh?
Right, you have to, a lot of people buy specific travel insurance to cover that. And this just gives you a quick look, and you've got all this. It just shows as the benefits are added, as we go this way across the board, the more you pay. Medicare Select, that's another type of supplement. In this one, it's kind of it's like an HMO, except you aren't restricted. It's kind of a hybrid, I always refer to it. It offers the same type of policies, but they limit you to a geographical area. You have to use the hospitals and doctors in their network to get full coverage, but the cost is considerably less. Where it differs from an HMO is that outside the network, you decide to go to that doctor up in Houston, MD Anderson or wherever, you still have your original Medicare. So Medicare pays at 80% or 100% if you're in the hospital.
So the snowbirds, would one of these plans be good for them? The people that live up East Coast and come down here for the winter?
Yeah, select plans are good for them because, you know, 90% of the year, they're home, they can belong to a Medicare Plus Choice plan and have the most reduced costs and benefits. But yet if they come down here for the winter, they can come here at UTMB, and what happens, they just pay the 20% of the co-pays. And for them, you know, for most of them, unless they got bad health, it's well worth it. And I think the biggest thing to remember is the plan you choose is, you know, tells you the level of care you're going to get. You have to know as much as you can about your policies. You really have to read them. You have to look at them relative to your own health and what you need. Because, you know, sometimes the plan is really cheap, but it's not going to give you what you want, and nor do you necessarily have to take the Cadillac to get coverage either. We're going to move on to the important part that's coming up, that's going to change everything, is the Medicare Modernization Act, and Jean referred to that earlier. Essentially what's happening is, which has already happened, everybody's got the drug, those who want them have the discount cards. In January of this year, the Medicare Part B premium went from $100 deductible to $110. And this is going to, and it's stayed at $100 for umpteen years. Every year you can expect this to raise exponentially with the costs. This November, here comes the critical time. This is when the first enrollment period begins to sign up for the prescription drug benefit and the Medicare Advantage plans. Then January 2006, that's when everything kicks in and goes into operation. And then this is real different. A lot of people don't realize in 2007, higher income beneficiaries are going to be paying a lot more. It's going to be based on a percentage of income for that Part B, which currently is at 90, what is it, 87?
Now, these people are only those receiving Medicare, like on their Social Security benefits. That's where the money's coming from.
Yeah, so you know, they're retirees. They're on Medicare, and should they decide to stay on Medicare, those are the things that are going up. One of the things that we see, you've probably read about it too. There are some doctors who were just getting out of the whole system. And what they're doing, they're offering people for X thousands of dollars a year, I'll take care of all your needs. And I think we're going to see more of that coming. Particularly going to see it, I think, in the upper income.
And they will not take insurance.
Right.
What about these people who are retired from the government, who have a very, very good insurance like High Option Blue Cross? Can they forego Medicare, and will that work just for them, just that?
I was going to get to it later, but I might as well mention it now. What is Part D? Initially, when it first came out, we thought, well, it's a choice you make, whether you want Part D and that prescription drug coverage. Well, what they are doing, they're plunking in, last I knew, at least $87 billion, just a few, so far, to the companies that offer retirement programs for their seniors, particularly the drug discount, drugs at $5 here, $3, like us. We get a good break on our drugs. And they're really subsidized a lot heavier as time goes by. But you know what happens? They're only going to do it for 5 years, and then all the money stops. And so you tell me, if you've got more retirees than you got active employees, there is absolutely no incentive to keep a prescription drug program for your employees. So that means, that's why I say middle income's going to get hit, because they're going to have to take out that Part D, just in case. They don't know if their drug program's going to be dropped. They don't know if they're going to fall into a chronic disease type situation. So they're going to be having that $35, $37 every month come out, which is going to go up every year. Because if you don't, you're penalized 1% a month from the time you should have signed up and when you actually do. That adds up to a lot, and then that percentage is taken on what the current rate is when you finally do apply. And you pay for the rest of your life. So I think everybody's going to have to sign up for it, like it or not. And I want to clarify the drug discount card. We've all talked about that. That strictly helped the low-income people. It was kind of a bust going out because most people did a lot better shopping on the internet or going to Canada or Costco or places like that. But I want to clarify, that's the drug discount card. That ends in January. And then we start talking about the drug benefit. And just in case some of you are working with seniors, low-income seniors, and they haven't got the discount card yet, the one that's still good through this year, I recommend it that they do because they get their 90 to 95% of their drug costs paid, up to $600. Granted, it's only for the rest of the year and it's going to die, but you know, when someone's really low income, that makes a big difference. And it goes until they've spent $600 and then it's gone. So if you're dealing with low income anywhere, you know, that's something to have them take advantage of, because so many seniors didn't, the low income, because they don't know about it. And even though a lot of stuff was in the paper, you know, when you're on low income, you think twice before you buy a newspaper. And what the monthly rate is on that is it's about $1,000 a month. If their income is about $1,000 a month or less, at least they're eligible for the rest of the year for $600 worth of drug benefits.
And it's just based on income, not resources.
Strictly income. Now the drug benefit, which comes in 2006, the beneficiaries will have to choose a comprehensive, questionable, standard prescription drug benefit. And the intentions behind this was that the new drug benefit for most beneficiaries will cut their drug bills in half, not their pills. And that's not necessarily true. Also coming, there's going to be new preventive care services offered. There's going to be the initial physical exam for all, because Medicare doesn't cover just going for a basic checkup. Usually to get covered by Medicare, you have to go in for a problem. So everybody, for newly enrolled only, will have a free physical exam, totally paid. The preventive services are going to cover diabetes screening tests for beneficiaries at risk for diabetes, and also will have extensive cardiovascular screening tests available. I'm sure some of this was available under the old system. It was just how you worded it and how you coded it is what made a difference.
What do you mean by cardiovascular screening?
They're not real specific yet. We will get the final details of everything in October and have to make a decision by the end of the year. They're also structurally going to concentrate on chronic care management, which hadn't been before, and they're adding some prevention benefits. And of course, which everybody's going to be involved in, is the electronic prescribing for doctors and pharmacies that are to improve quality. But now let's take a closer look at the actual drug benefit. First of all, there's a $35 monthly premium. That's for this year only. It's going to be going up every single year. There's a $250 annual deductible. That's going to go up every year. Then you get 75% coverage then until you hit $2,250. Then you hit this big hole. You have no coverage until you have hit the $3,600 a year, or what they say, out-of-pocket costs of $5,100. Then when you get up to that catastrophic range, of course, then you get 95% coverage. And I went to a seminar, they're talking, they looked at all the seniors, those who have drugs to those who take absolutely the maximum. And the average cost per drug, a drug bill per year for seniors, $3,160. So as you can see, a lot of these people are just going to fall in the hole. And when they talk about out-of-pocket costs, say you are in a drug program and they don't carry the drug you want, so you decide to go buy it yourself. If it's not in their formulary, it's not considered part of your out-of-pocket cost. You have to buy their formulary.
For those, okay, say you have a healthy person, elderly, and don't really have any maintenance drug, okay? They still have to enroll and pay this $250 a year plus this $35 monthly. So they're actually worse off than before.
That's why I said it's like the good and the bad and the switch around. And yes, so you're a healthy person. You anticipate being healthy until the day you drop dead maybe. But you don't know what's going to happen. Therefore, you're going to be paying $35 every month. And it's going to go up. That's for the first year. Every year it's going to go up. And you look at that, that's a hunk of money. But if you take 1% of that a month and add that to the monthly premium, for every month that you didn't get it, say for 5 years, you stay healthy and suddenly you need it. Can you imagine what 60 months, 60% premium, and it's based on the most current price when you apply? It's like, you know what you have to do? You have to look at this like car insurance. You pray to God you never need it, but you've got it in case you do. That's the only way I can think of it. Now, as I said, enrollment is voluntary. And the thing to remember is you don't automatically get it. You have to apply for it to get it. You know, like Part A and Part B, when you go on Social Security, you automatically get it unless you actively fill out a form and deny it, that you don't want it. In this one, you're going to have to take an active part, and you're going to have to apply for it to get it. And they expect, as far as drug plans in Texas, close to 40 different plans to pick from. And do you realize how hard that's going to be for seniors to go through all this and try and figure out what is the right drug program for them? And some of them, there's going to be 146 categories of drugs, and there's required to have 2 drugs in each category. And, you know, where you would think something like statins or something like that, everybody takes a lot. That's not a category by itself. There's other ones in that category. So, and what happens, you know, they may have really good prices. They may have the drugs you want to attract you to sign up for the program. But then with 6 weeks' notice, they can change the drugs they handle. They can change the pricing because there's no control on pricing. But you can't do anything about it for a year. You can only change health plans once a year, you know, at the beginning of the year. There is one exception to that changing once a year. What they are doing with nursing homes, anybody that deals with nursing homes, they're considered dual eligibles. That means somebody has Medicare and Medicaid. And a lot of this I don't have on slides because I just picked it up yesterday and the day before it came out. But with dual eligibles, two things are going to happen. First, we have the people in the nursing home. And what they're going to do, and I feel sorry for the nursing home administrators, they're going to take everybody in a nursing home and they're going to randomly assign them to a drug program in November or December. So then here is a nursing home administrator having 20 different suppliers or trucks coming every day to deliver drugs, and who do they contact in an emergency? So that is the one group that can change at any time. But that is going to be a big job for a nursing home because they're going to have to work and get everybody reapplied to maybe a common 1 or 2 plans. So I'm glad I don't work in a nursing home anymore. The other thing that's happening, and I think this is really important for everybody to know, in May, the Social Security Administration is going to send out a 9-page application to everybody that is a dual eligible on Medicare and Medicaid. So that's going to go to all the low-income people in the country. And they have to fill out that 9-page form and send it in to be pre-qualified for the drug program. So that's going to be a problem. They're going to get that and not even know what they're supposed to do with it, let alone fill it out and mail it. But that doesn't get them the drug card. They still have to in October when the programs come out, which we don't know about yet. Then they're going to actually have to apply for the program. And all this is active on their part. So if anybody's looking for any outreach opportunities and have to help the community, these people are really going to need help.
So in May, they're only sending this application letter information to the low income, not to all seniors.
No.
65 and older.
Only the ones
Strictly dual eligible who are on some sort, that'd be who are on any kind of government program, state or federal, like SSI, disability, that type of thing.
Everybody that doesn't get a letter is going to be calling.
Isn't this...
Yeah, and I mean, these people are going to need help. Some people will get stuff in the mail. You see something from the government, people throw it away. You know,
Is this automatic for nursing home residents? They don't have to apply?
Yeah.
Who's going to do it for nursing home residents?
We don't know.
We don't know. It's just the government. Somebody in the government's going to randomly assign them up, and then the administrator, the staff of the nursing home is going to have to get them all lined up with somebody else. Yes.
So you said dual, you said dual, people that are Medicare and Medicaid?
Yes.
So the person that's just Medicare would not receive this? It's
No,
just the dual, okay.
And what, you know, at least the duals are being notified something is happening. It's all the people who aren't on Medicaid. I mean, I go out and do these talks, and they tell me it's the most depressing thing they've heard in their whole life, but they're grateful. But, you know, I've only contacted a few hundred people by doing talks. I mean, we got thousands just in our county who are going to be absolutely blindsided by it. And what's going to happen if they don't take an active part, or the low-income people don't fill out that 9-page form and sign up for a drug program? They're going to walk in January 2nd, the day after New Year's, want to get a prescription, and they can't get it filled. Somebody's going to have to give it to them because it's going to take a while to process the forms. So I think we need as much outreach as possible.
Like a health fair.
Yeah. And then, yeah, a lot of people just don't go to things. You know, that's going to be the hard part.
Well, those who kind of even get us, you know, household program.
This is another thing that's disappearing. You know, everybody's taking advantage of these pharmaceutical companies where they've had some great programs. And they've, you know, with the help of the, you know, they could apply and get these. I understand these are totally going away. Low-income assistance programs. You know, this medicine, needy meds, RX assist, those are going to be going too because, you know, this is all going to be covered by the new drug program. And I don't know what's going to happen. There's certain ones like the rare disease. You know, these are people where people have really rare diseases and Alzheimer's and things. They would help pay for the drugs of people with these problems. And on a sliding scale, I don't know what's going to happen here. They probably won't be subsidized by the drug company. I don't know. And if anybody is a veteran who has 6 months of active duty service, I would certainly scoot over to the VA because nothing's going to change there.
Is Medicaid completely going away as
Or as medication?
It's hard to say what's going to happen.
Isn't that what Dr. Feather said? Did he say that? I mean,
No, it's not going away. It's just coming in a different form. And basically, the way this is a way to control Medicare costs. I mean, it's a shame they're privatizing because an awful lot of money is going into that. And Canadian pharmacies, they're still available. That'll help those people, you know, who are in that little middle block. They're paying at $35. You know, at least these are good Canadian pharmacies, incidentally. They're legitimate. But they're working real hard to drop that program, too. And
Make it illegal, right?
yeah, and you know, it's what they say, well, you shouldn't get the drugs, you can't trust them. And it's kind of crazy because their drugs were re-importing us. So they're telling us their drugs are bad. That doesn't make a lot of sense. One of the things that can help a lot of you, if you are working with seniors, and of course they can't get the information plugged in until they get it themselves in October, there is a program called Benefits Check. And it's only available on the computer. But it has 3 categories. One category can help people with rent, property taxes, heating bills. The other one goes in, and you have to put personal information in, and it is a guaranteed site of security. But you put in your income and all that stuff. It's going to help you find the lowest cost medicines or program for you. But you know, to get all those in, it's going to be a big job because they've got to put the whole country in.
Is that not there? No, you didn't have that.
Oh, it should have been, maybe it's attached on the other one. Should be, there's a second thing. Then we have Medicare Card Finder, but that's kind of going out. You know, that's only good for a few months. I did want to bring your attention to this. This was a separate handout on our table, and I don't know if you've all got it. It's called, by the Center for Medicare Education, Prescription Drug Benefits under Part D. This is a multi-page, very detailed explanation of what's happening. So I think everybody would like to read this in depth for what they know. There's so much they don't know.
Can you go back to your benefits checkup?
Oh, I've got that. You got that coming. Let me show you here. Resource information, you should all have this. AARP, who was all for this new program, now they're backpedaling because they realize what happened. But they've got 800 different sites on Medicare, Social Security, and legal help. The Kaiser Foundation, they're doing an excellent job of getting material out on what all the latest info on Medicare, on the new Medicare Modernization, on drug formularies, and they're actually doing webcast training for people who are interested. Also, this is the access to benefits or benefits check-in. I've got the numbers, and all these I have the websites. And for this, so that's kind of what I was showing you before. And it tells what they help you find. Medicare.gov, of course, they're a little pro the government and all the new changes, but the information is still there and what you need to know as things start coming out. They're supposedly putting a bunch of money into these, what they call SHIP, the Texas State Health Insurance. And what they did when we lost all the HMOs 6 years ago and created a nightmare, people could call them, give them their personal health information, where they were financially. They would help people make a decision. The SHIP. And they're funding them to have more people to provide more help. And then the Medicare Rights Center, that is an independent provider of information. They've lost some of their funding, but they still put out some very good information. And a couple other things that affect, I just got today, I thought was interesting. Medicare is going to automatically cut payments to doctors by 4 to 5% each of the next 6 years. The estimated total cut is 26%. And, huh? 5 years.
5 years?
And the Medicare Part B premiums, they expect to increase over the next couple of years or so up to $139 a month. It's going to be $89.20 next year. So costs are really, really rising. And the thing you have to watch is people shouldn't do anything now. Because a lot of companies like Spring and some of them that are HMO type things are out selling, trying to get people signed up to get a corner on the market. And they're particularly looking for healthy people to offset the bad health costs. And the thing is, don't do anything until everything comes out and you can make an intelligent decision. Already there's scams out all over the place. And I mean, I really worry about that because the elderly is our most vulnerable population. And that's pretty much what it is. There's, I think, no price controls on medicine, that type of thing.
Do you think that UTMB will continue to have, I know you kind of touched a drug benefit, let's say for those of us that are planning on retiring from UTMB?
You'll have it, at least they'll have it for the next 5 years. So much of that is going to be
UTMB retirement?
Yes.
Another thing that's real interesting, some of you probably deal with drugs like Xanax and stuff, that you use, restrain people, particularly nursing homes. You can't use physical restraint. Those are not covered by the new Medicare drugs.
Ativan is not covered.
Yeah, it's got to come from somewhere.
If the drug company
The states are losing the funding that
feel
they
like
can.
they are discriminated. The makers of Ativan, for example, they might feel.
What it was part of an old proposal a few years ago, and someone just copied it and put it in the new one, and no one looked at it. Yes?
My greatest concern with all this is some of these elderly are not going to be able to afford this because they're on fixed income, so they're not going to take their medications. So we're going to see more people coming into the hospital sicker.
Yes.
So we're really not thinking about, well, I'm not trying to point a finger, but what about the overall picture? Because in the end, you're going to end up paying more money to have to take care of these people because they're going to come in more chronically ill.
Yeah, the big question, who is going to pay?
And the management of chronically ill, which is new.
It's a way of getting rid of people. That's what the whole plan is set for.
No longer believe that phrase, I'm from the government and I'm here to help you. Any other questions?
More and more of us are getting older. We're going to be in this population very soon. I mean,
and I think me before you, I'm worried.
Before it gets for me, so the big message, if people can really hear it, is take care of yourself, know how to do your health promotion. I mean, avoid McDonald's, alcohol, smoke, pot, and all of this crap. And stop all of this that is coming that is making people wealthy by contaminating with illicit drugs and things like that. And if people don't learn to take control and responsibility for their own health, please respect of what is going to happen. That we are all going to die. Nobody's going to be here forever. I mean, this is true. But at least let's go out in dignity and in peace, just like the Pope did. No tube feedings, no artificial ventilation, nothing that prolongs life. We're not here forever. We just have to learn how to live right.
Dr. Silva is just 100% right. You made a good point. Our best defense is good health. And I mean, you can't say enough about our exercise programs we have here, but it's healthy eating, and I get on and off my kicks, but I sure got to get back on it again.
Can I ask you, this formulary, limiting 2 of each class or whatever, is it going to apply to acute care and SNF?
Yes. Everything.
Everything's controlled by
It's going to be all controlled. It's going to be controlled program. And then the SNF, they're going to start charging them $100 and something a day after so many days, 20 days.
So are you going to do education in the nursing homes?
That I need to, and I need to do it now to make them aware,
Right.
and so they can start planning. I'm concerned about getting education out to the low income, and then once all this hits, to get out and do a whole new education program. And whatever's wrong, we cannot fix the system for 3 years. Because the president did say, we want to get it in, we want to get it in effect, and any change that is proposed will be vetoed. So we're going to have to work through all the kinks for a few years before changes can be made.
You know, the other concern there is, you know, now they're covering chronic care, and you don't know what's going to come up, you know, as far as chronic care. It would just be like when they started covering ESRD. They didn't know that there were so many people coming out of the woodworks. And so it's still going to be more expensive.
Yes.
Instead of a cookie break, we have a Prozac and Paxil break.
Yeah, that's what we need. You had a question?
You briefly mentioned that I know with, I work with hospice patients, and so I know as far as if you're on hospice, it's through Medicare, and then if you needed a provider, usually you have to have Medicaid or be eligible for Medicaid. So for that middle income that doesn't want to put their loved one in a nursing facility, is there any provider resources if they have Medicare but they don't qualify for Medicaid?
A lot of those, I think most of those are going to disappear unless you've got things like special ministries.
I have a related question, because it was in the very beginning of your talk you were talking about Part A, and you said it did cover some hospice services now, but I didn't catch that. Can you repeat it?
It covers hospice care, and that's basically in the home with a co-pay for, you know, the pain medicine, that type of stuff. Okay. But if you have hospice care in the hospital, there's a daily charge on top of that. So because hospice is under Part A, you know, unless they got something, see, we don't know what it all is yet. We're waiting for the big surprise come October. I can only assume right now it will still be the same as it is.
If they're at home, their medication would still be under Part B, right?
The medication in hospice is covered by hospice.
Oh, okay, that's right. Yeah, it's all like a DRG thing.
Yeah.
So basically, right now, we need to educate our patients that are Medicare that they need to be looking for something in October.
Right, and and I think and anybody deals with low-income people, whether it's clinical or hospital, I think we need to let them know something's coming that's going to critically affect their life, this form. And they need to fill it out, and if they can't, they need to go to their senior center or someplace and get help to get this form filled out, because they'll have nothing January 1st. And I'm afraid a lot of them won't.
And it was intended to help them.
Yeah.
If you want to organize a little workshop.
Oh, there's a question back here somewhere?
I can volunteer to help.
I think the lady in the pink shirt was asking a question.
Someone there.
She has a question.
Is there a question at one of the other sites? I think we may need to take your mute off. I think your mute is still on.
Can't hear you.
Can you take the mute off? It should be there.
Yeah,
There you go. Okay, do you have a question?
Repeat your question.
Could you please repeat your question?
Maybe her mute didn't come off.
Did you have a question? I'm sorry.
Okay.
What I want to do real quick is also to maybe think that...
Not just talking.
I think she's talking to somebody else.
Oh, okay.
Okay.
Across the room, there's other people on the other side. A couple days ago, Dr. John Feder, who's the CEO and Executive Director of the American Society of Consultant Pharmacists, gave a really good overview, and Penny covered a lot of those really important points, and there's some other things in here that would be good information. I have the presentation that he gave that I'm just going to pass around.
And normally this is a 2-hour presentation, so I really had to scooch it together, but I still wanted to cover it.
And really cover the highlights of that, and take a look at that, because there's there's other terms and there's
Yeah.
other issues that go on with this really important change.
You know, the one here, it's on here, so you still have the ability to utilize it.
Ms. Rudd?
No, I'm asking him
Yeah,
first.
there's supplemental, but you have to have Medicare.
People-
Supplement to Medicare.
Yeah, you gotta have Medicare to get a supplement, and
Right.
people can keep their supplement, or they may end up wanting to change supplements because this person's supplement's gonna offer a better drug pricing than this one. And I don't know if I mentioned, but when you do get on the drug program, on that program, besides all the deductibles and co-pays I've mentioned, every drug program is gonna have its own set of deductibles and monthly co-pays and limitation, plus everything associated with Part D. And I don't know how you're going to figure out. You're really going to have to sit down and figure dollars and cents what to do.
And then get ready for.
Just like I
And then if you get something chronic, if you don't go with it, hopefully you've got a wealthy benefactor somewhere who's going to pick up your bills.
But it's not all negative. It was one of the last comments that came up is that there are positive things about this change in the drug program.
For the
For the low income.
There is a
Better than
drug
what's out
program.
there now.
It benefits the very
The very
if they will apply
Yeah,
in time.
the comment was made yesterday. What wasn't taken in consideration yesterday's comment too, it said, was the fact that we're paying for it now too, whatever they've got, and we're going to pay again. It's just that the only difference is the low income are going to be really helped, and the middle and up are going to share a bigger responsibility for their costs.
And I think the formulary is going to really limit the cost
And the
for
formulary,
Medicare.
formularies will limit costs, and they can change at any time.
And it's gonna
Yeah,
affect
but there
how
are
we
only two
treat our
choices,
Mm-hmm.
you know.
Yeah.
I mean, nobody's going to say anymore to the doctor, oh, how about this?
Yeah, you aren't going to get those cute things advertised of those brand name or the new, what I call designer drugs.
Yeah. The purple pill.
But the other thing is, will the low income really be helped, because they're the ones that don't usually go out to hear about the changes that's forthcoming and have someone really distinguish the differences so they won't be taken for scams or, so will it really, the benefit that we're aiming at?
Getting the information is real
I have a
important.
problem with them paying monthly $25. I mean, I can see how they stop paying it, and then they're gonna go and try to get their drugs, and then
The
they're not
very
gonna be
poor
able
will
to.
not have to pay those monthly fees.
Yeah, the very poor, they're,
It's in the handout.
Yeah.
Tony just gave you.
That's why they have the eligibility, you know, that they said in May.
yeah, the very poor are going to get the deductibles covered and that monthly $35,
They do
yeah.
have to pay monthly.
No, that will be covered for the people who are 100% or below poverty.
100% of the coverage.
Oh, that's good.
Yeah, and the real specifics are on the handout.
It's in that handout.
No, Medicare.
Really good.
65.
So if anybody's looking for a mission in life, whether it's here or at their church or groups, you've got a good one coming up.
Oh, I was going to ask you, who is going to be, I mean, there needs to be a lot of people who will go out there and educate, you know?
Yeah, exactly. And who's staffed and who has the time, that's a big thing in this market today.
Well,
There's a really good website like that one you showed. People can, you can sit down and help people plug it all in.
Yeah.
And come up with the choices.
Yeah, no, yeah, definitely. Social workers would be very busy.
So I'm thinking if I'm 65 rows, I'm thinking, okay, do I get my drugs this month or do I pay
Eat.
my gas?
Or eat.
Oh, you
Gas,
have to, you won't have to.
drugs.
you have to walk to the drugstore.
That's
Do you know
I
the,
can't buy either one.
So you better not have COPD.
that last option I had on one of the very early sheets, if all else fails, moving your kids and let them pay, I think that's going to become a top one coming up.
What, you'll be their dependent? And be under your
That
insurance?
trend is happening with the new generation. They want to stay home with mom till they're 35. I'm just praying that they leave.
Yeah.
I'm just like,
Penny, would
Like, I'm
the
trying to get
parents
it.
become a dependent?
Depends on the situation, income tax wise it can.
If they have resources, if they have over I think it says $6,000 of resources, they don't qualify.
But see, under the tax code though, if somebody is caring for a parent in the home, sometimes there is a tax deduction for that.
If you pay over 50% of their whatever expenses.
Their
that
care,
the tax
50% of their care is
they are
tax.
dependents.
And as Dr. Silva said, we have to also look at our advance directives and seriously think about how much you know, there's a point that you do a lot of things because you got a chance of recovery. And you can be very specific, so I think everybody needs to look at that also.
Thank you.
All these